Hello, guest of the Retina Channel podcast. Welcome to another episode of this series, the Retina Channel podcast. I'm your host, Dr. Kevon. I'm based in Toronto. I'm an ophthalmologist. I'm a retina specialist. And the purpose of this podcast is to bring you what's new and interesting in retina. And especially if there's new articles in the field of retina, we'll be talking about them. And hopefully you folks will learn from the interviews and stay up to speed in what's going on in our field. Well, today's guest is a returning guest to the podcast. He needs no introduction for those of us in the field of retina and ophthalmology. He's Dr. David Sarraf from UCLA, and he is here on the podcast to talk about a new article that his group published in the Journal of Retina, and it's about the pigment epithelial detachment, size, and variability on the visual acuity outcomes and the change in improvement in HAWK and HARRIER studies. So those are studies that investigated the role of berloxizumab, which is not used as much anymore, but regardless, it was a very strong anti-VEGF medication, and to look at those patients and see how were the outcomes correlated with the pigment epithelial detachment size at the beginning or at week 12 of the study. And it teaches us a lot about the significance of pigment detachment, and we'll get into more details of the article with Dr. Sarraf. Just give you a brief bio on him. He's a clinical professor of ophthalmology at the Stein Eye Institute at UCLA. He's a member of the Retina Disorder and Ophthalmic Genetics Division. He has published over 400 peer-reviewed articles, case reports, reviews, and authors over 30 book chapters. And he's also the co-author of the second edition of the Retina Atlas and the seventh edition of the famous Ryan's Retina. He's a world leader in the field of ophthalmic imaging and delivered over 450 invited lectures at various meetings worldwide, and also more than a dozen endowed and keynote lectures. Specifically, recently he was awarded the Lou Esther T. Mertz Lectureship Award with the MACULAR Foundation in 2018, Canadian Journal of Ophthalmology Keynote Lecture by the Canadian Ophthalmological Society in 2020, and the 2023 Richard Green Award and Lecture by the Macular Society. Well, Dr. Sarraf also sits at the board and editing sections of many journals. For example, he's associated editor of the British Journal of Ophthalmology and Journal of Ophthalmology Science. He's a section editor of the Ocular Imaging section of the Canadian Journal of Ophthalmology. He's an associate editor of the journal Retinal Cases and Brief Reports, and the editorial board member of the Journal of Retina and OSLI Retina. He's also serving as a current program chair for the Macular Society for the meetings in 2024 to 2026. His focus of research is vast, but he's well known and well regarded in the field of advanced retinal imaging. He's been a pioneer on the clinical applications of OCT angiography, and also applied his technologies to better understand the structure and arrangement of retinal capillary plexus and ischemic cases in occlusive retinal disorder. We all know about the word PAM, and that is due to the work Dr. Sarraf has done in the field of ophthalmic imaging. He's also an international authority in the field of AMD and published extensively on the subject of pigment epithelial detachment, which brings us to the article we're going to talk about today. Well, without further ado, let's have the conversation with Dr. David Sarraf.
Hello.
Hi, Kevon. How are you?
Hi, David. How are you?
Good. How's everything?
Everything's great. I'm very glad we could connect. I really appreciate you coming on the podcast again.
My pleasure.
Welcome back.
I tried to find the time to do this with you. Sorry for the delay, but I appreciate your
Oh,
patience.
no worries. I'm very glad that you could make the time. Really appreciate it.
No problem.
So, David, as you know, we're going to talk about the article your group published in Retina not too long ago on an analysis of HAWK and HARRIER studies. that you guys did on the PED variability and PED height and its effect on the outcomes of neovascular degeneration treatment using brolucizumab and aflibercept combined arm. So if, for the listeners and viewers, I'm going to just give a 1 minute overview that you combined all patients in HAWK and HARRIER who has 6 milligram Brolo or 2 milligrams aflibercept into a big sort of a treatment agnostic group, as you call it, about over 1,400 patients. And you look at those patients who had anti-VEGF and look at the PED size at baseline, week 12, and also year 2, and correlated that with visual acuity improvement and see what results you get. And overall, you showed that PED height at baseline and week 12, it does affect your outcome, and also variability affects your outcome. So I just want to hear it from you and maybe get some in-depth discussion. Is that okay?
Yeah, you say it better than I could. That was perfect.
I don't think so. I don't think so. So PED actually has always been a bit of a black box for me, at least in retina. You don't know what to make of it. You don't know, because if someone only has a PED and no fluid, you tend not to treat for most people. But then you don't know what to make of it. So I'm glad you published this study. So can you tell us a bit of a background of this study, why you looked at this?
Well, I mean, we had this robust data set available to us through Novartis, and the especially appealing aspect was the fact that we weren't comparing drugs here. We were pooling the data. And it also was, I think, a newer age study. So we had very good volumetric OCT data available to analyze. And you're right. I think the inclination, I think guiding treatment, the treatment guideline has always been to look at subretinal and intraretinal fluid and not consider sub-RPE fluid, which is probably not a precise way. Probably you're missing some valuable information, ignoring PED thickness and sub-RPE fluid. So given that we had this robust prospective data set with the sophisticated OCT analysis, it was a good opportunity to combine the data and get some idea of how PED thickness or PED height as relates to sub-RPE fluid could affect outcomes. And we also correlated it with subretinal and intraretinal fluid to see if there was any association. So that data was recently published, and I think it is important data that shows you that you should look at sub-RPE fluid or PED thickness when you're evaluating patients after treatment.
Mm-hmm. So I think you divided the PED size over 200 microns, 300 microns, and 400 microns, whether it's less or more than any of those thresholds. And for all those three thresholds, the larger PED meant less visual gain throughout the 2 years, all points, at all measurement points, which I find interesting, very interesting.
That's right. So at baseline, we divided it into 4 quartiles. And also we looked at PED thickness or height at also at 12 with the 12-week visit. And we found, yes, for each quartile, 100 less or greater than 100, 200, 300, and 400, the lower thickness group fared much better in terms of final visual outcome. And so that indicated that the smaller the PED, at least the lower the PED thickness or height, the greater likelihood that you'd have a better visual outcome. And then the PED, we also looked at all 4 together, and PED at 400 did the worst of all the 4 groups. And even we took out RPE tears, while all the 3 other groups, less than 300, less than 200, and less than 100, those 3 groups all improved visual acuity, and while the 400 group lost vision.
Interesting. So regardless of the presence or absence of a RIP or a tear in RPE,
that's right.
Large PEDs lost vision.
It was an especially poor outcome when you looked at 400 the total cohort of patients with 400 micron thickness PEDs or larger. But even if you took out the RPE tears that developed, the curve was still on a decline. Whereas with the PED thickness less than 300 and the less than 200 and less than 100, there was a gradual a steady trend of improvement in visual acuity.
Was that correlating with the agent used to treat it? Like, was it brolucizumab or aflibercept, or could you look at that separately, or did it matter?
I know that we looked at that. I think we have another paper where we're looking at that, and that would be published, I think, down the line. But in this particular paper, we just looked at the aggregate data.
So I guess that's important. If I'm treating a patient with new onset neovascular AMD and they have a large PED of more than 400 microns in height, maybe I should counsel them and telling them they could still lose vision despite the treatment. Is that correct?
I think so. I mean, we've showed in many studies before as well that PED thickness of 4 to 500 or larger, they're at significant risk of tear. But even beyond the risk of tear, there's a poor visual prognosis. Yes, so I think it makes sense to educate the patients, to temper their expectations, and perhaps be more aggressive with therapy too. You know, if you see large, especially I think in how I manage patients, if I'm seeing that there's an increase in the PED thickness without the development of fluid or SHREM, I'm going to treat those patients. So I look at PED thickness in order to guide management. And even if and even without follow-up data, if you have a fibrovascular PED of significant thickness, you should consider aggressive therapy, keeping in mind the risk of RPE tears.
That's very important. That's very important. Also, you looked at the variability of PD, I think between weeks 12 and 96, and you showed more variable they are, there's less gain in vision. Can we talk about that a bit, please?
Yeah, so we divided it into quartiles again. In this case, I think it was the lowest quartile of variability in PED thickness was less than 10 microns, and the greatest variability in PED thickness was about greater than 30 microns. And
Yes.
the group that had the greatest variability, especially the group with variability of 30 microns or more in the PED thickness or height, that group had the worst visual outcome, I believe, at 12 months. And so PEDs that are fluctuating significantly is something you want to avoid. And again, that may speak to more aggressive therapy, keeping the PED flatter, I think. You don't want to see PEDs bouncing up and down. I think there's been some data previously showing that with the significant fluctuation in fluid as well, there can be a more adverse visual outcome. So again, I think it indicates that we need to be aggressive with PEDs. We shouldn't let PEDs progress to significant heights or thicknesses, and we should be more aggressive in trying to keep the PED route. I don't think you need to have them flattened out completely. That's usually not possible with a type 1 neovascular membrane anyways, because they organize under the PED, but you ideally want to keep the fibrovascular PED at a baseline lower thickness and avoid increases in PED thickness. And I think you can do that by having maybe a more aggressive interval of injection.
I guess more fluctuations could mean more aggressive neovascular complex to begin with, type 1 usually. So that could also speak to that.
That's right. And also the larger the PED thickness, the more likely there's intraretinal or subretinal fluid. We showed that in this paper as well. And this can affect the integrity of the anatomical zones, like the ellipsoid zone and the outer retina. And so you want to avoid these complications, fluid and significant heme, which may also be a risk of a more aggressive neovascular process. These can all compromise the integrity of the anatomical barriers, and so again, you ideally want to keep the patient with a PED that's relatively shallow without exudation as consistently as possible. I think
Yes,
with
yes.
more aggressive injections.
So I think this is essentially more variability you showed has more fluid, intraretinal and subretinal fluid, and less visual gain, which speaks to what you just talked about. It's wonderful. Okay, so that's great, Dr. Sarraf. So anything we should remember? I mean, this is fantastic information. What do you want your readers and listeners to remember from your article? When, like a punchline take-home message, how should we deal with these patients or neovascular AMD based on what we learned from your article?
I think that the tried and true biomarkers of neovascular activity that guide anti-VEGF therapy are subretinal, intraretinal fluid, and SHREM, and heme, of course. But I think retinal practitioners should also look at the PED thickness. And when you see a PED is growing or there's a significant thickness, that should be also a marker of activity that should, I think, trigger more aggressive therapy. And avoiding using this biomarker in addition to fluid, I think, will portend better visual outcomes. So look at it like fluid. I think PED thickness is an additional value and merit to study.
Wonderful. Thank you very much.
Okay.
I learned a lot from your article chatting with
I
you. I
appreciate
always
that.
learn from you. You are one of the pillars of our field, so it's always a pleasure to chat with you. And
Always
thank you for
nice to see you.
thank you for all the contribution you have made to our field and also this article and coming on the Retina Channel podcast. And I look forward to seeing you soon again, hopefully.
I'd love to see you again, Kayvon. Thank you for highlighting the paper and your kind words. And it's always a pleasure to talk with you and to discuss your insights, your intellectual insights with ophthalmology, which are most appreciated.
Pleasure's all mine. Thank you.
Thank you.
Well, that's it, folks. This wraps up episode 75 of the Retina Channel podcast. I hope you learned from my conversation with our wonderful guest, Dr. David Sarraf, about the significance and the prognostic value of pigment epithelial detachment on the outcome of neovascular AMD treatment. I think I know more now how to counsel a patient, what to expect from my therapy when I start a new patient for neovascular AMD. Well, a bit of a heads up about our next episode. It's going to be about ophthalmology, but not retina. It's going to be on EDI, equity, diversity, and inclusion. It will be a conversation with two leaders of ADI in Canada, Dr. Nina Ahuja and Dr. Nupa Bakshi, who have recently published an article along with their co-authors on the EDI landscape in Canadian ophthalmology residency programs. And that will give us a chance to discuss EDI more, learn from these two experts, and bring that more to the forefront so we could all benefit from learning about it. Until last episode, I wish you all the best. Take care.